Good afternoon. Welcome to the webinar on a toolkit for counseling and dissemination of the pregnancy weight gain guidelines. Our speakers for today will be introduced by Dr. Kathleen Rasmussen, Professor of Nutrition in the Division of Nutritional Sciences at Cornell University. Dr. Rasmussen served as the chair of the consensus committee that recommended the revised pregnancy weight gain guidelines. She also served as chair of the planning committee on implementation of the pregnancy weight gain guidelines, whose work will be presented today. Just a few quick things before we get started. The audio for today's event will be streamed through your computer speakers. We will be taking questions through the Q&A box located in the lower right-hand side of your screen. Simply type your question in the box and click Submit. We ask that you leave the box set to send your questions to all panelists. This webinar is being recorded. Please understand that any questions you submit may be read aloud and included in our recording. A link to the recording, as well as a copy of the slides, will be posted on our website within the next week or so. If you have any technical issues during the event, please contact WebEx technical support at 1-866-229-3239. Once again, the number for WebEx technical support is 1-866-229-3239. With that, I'd like to turn things over to Dr. Rasmussen.
Good afternoon, everyone. It's my pleasure to be with you this afternoon. Today, in addition to me, there will be three people speaking. Dr. Michael Liu, a physician who is the Associate Administrator for Maternal and Child Health in the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Dr. Liu's experience includes maternal and child health research, practice, and policy. He is best known for his research on racial ethnic disparities in birth outcomes, and he was a member of the committee that produced the 2009 book on reexamining the weight gain guidelines. Dr. Liu will introduce today's webinar, and then I will follow to present the context for our work. Dr. Anna Maria Segaris will follow me. Dr. Segaris is professor in the Department of Epidemiology with a joint appointment in the Department of Nutrition at the School of Public Health at the University of North Carolina, Chapel Hill. Dr. Segaris has expertise in gestational weight gain, maternal nutritional status, and its effects on birth outcomes. Dr. Segaris will present our specific products that are accessible on the webinar for today's web page. Then we will be joined by Dr. Patrick Catalano, a physician who is professor in the Department of Reproductive Biology at Case Western University at Metro Health Medical Center. Dr. Catalano's research focuses on insulin resistance and glucose metabolism in pregnancy and the role of placental cytokines in the regulation of fetal growth and adiposity. Dr. Catalano is board certified in maternal and fetal medicine. Both he and Dr. Segaris also served on the committee that produced the 2009 revision to the weight gain guidelines. He will join Dr. Segaris and me as a panel to answer your questions this afternoon. We'll have lots of time for that, and we're looking forward to receiving them. I'd like to begin now with Dr. Liu. Please go ahead.
Good afternoon and good morning to some of you. I'd like to join Dr. Rasmussen in welcoming all of you to this webinar. The Maternal and Child Health Bureau is proud to have played a role in supporting the development of the toolkit, as we are in supporting the development of the first pregnancy weight guidelines back in 1990, as well as the revised guidelines in 2009. We recognize the importance of helping women achieve a healthy weight, and not only during pregnancy, but before, between, and beyond pregnancy. We also recognize that it's not enough to just put out guidelines, that we need to support women and their providers in meeting the guidelines. And that's what this toolkit is all about. It's got booklets for patients and providers. It's got posters and interactive website. It's got an easy-to-use weight tracker and other products. Now, I want to take a moment to thank the IOM and the committee, and especially Ann and Kathy for their leadership in developing this great toolkit. Now, it's up to us. All of us who care so much about improving maternal and child health in this country. All of us who care so much about improving women's health in this country. How do we take this great toolkit and apply it to our practice and to our programs to help women achieve a healthier weight before pregnancy, gain within guidelines during pregnancy, and help them get back to a healthier weight after pregnancy? At MCHB, I'm certainly going to look for opportunities to do so through our Title V MCH block grants, our home visiting programs, our Healthy Start programs, and many other programs. I hope you will pay close attention to the presentations, ask questions, offer suggestions during this webinar, but most important, I hope you will take this toolkit back to your offices and your clinics and ask all of your colleagues, residents, students, and clients to use it. That's how we're going to move the needle on gestational weight gain. That's how we're going to move the needle on achieving healthier weight for women and children in this country. So let me thank you in advance for that and turn it back to Kathy.
Great. Thank you so much, Michael. Let me see here. We have to make the slides move. So you can see my picture, and then let's move on to our presentation. Today, we'd like to introduce you to the materials that we have prepared as part of the Dissemination Committee's activities. Some of these are shown in this poster. When I'm done, one of the committee members, Anna Maria Seeger-Rees, will discuss them in detail with you. But before she does that, I wanted to position these materials in the current context of women's behavior and also tell you how we thought about dissemination of the 2009 Gestational Weight Gain Report from a broader perspective. What I'm showing you here are the very latest data on women's weight gain during pregnancy, kindly provided by Andrea Scharmer of the Centers for Disease Control. In this slide, women's gestational weight gain is expressed as below, within, or above the gestational weight gain guidelines for each of the BMI categories: underweight, normal weight, overweight, and obese. We only have data adequate for calculating gestational weight gain, because you need height and pre-pregnancy weight to get the BMI category and calculate gestational weight gain, from 28 states in New York City, which is what's reported here. As you might guess, one of the 2009 committee's recommendation was that this capacity be extended to all states. If you focus on the four bars on the left, you see that only a minority of the women, 24.6 to 40.7 of them in the four major BMI categories, gained within the 2009 weight gain guidelines. In fact, more than 70% of overweight and obese women gained outside the guidelines, and most of that was in the direction of overgain. The three columns on the right are all of the obese women divided into obesity classes 1, 2, and 3, respectively. These are data that were not available to the 2009 committee as they had not been calculated. They are compared to a guideline that applies to them but was primarily based on data from women in obese class 1 because that's what we had available to us. One might hope that heavier women would gain less, and indeed, as obesity category increased, a progressively greater proportion of the women undergained. We don't yet have sufficient outcome data to determine if undergaining is the right thing for these heaviest women to do, but we can see that 20 to 32% of them are gaining less than 5 kilograms. The point of these data is to make clear what we expected when we wrote the report, namely that many women would be gaining outside the new guidelines. This is one of the reasons that we must disseminate these guidelines widely, and also a reason why we must think more holistically about the care that we offer to women of reproductive age. My next slide illustrates that this is truly a complex problem. This graphic presents the conceptual framework that the committee developed to guide its work. The target, women gaining within the guidelines, over here on the right, is over here on the right. However, there are, in fact, many places where intervention could occur to increase the opportunity for a given woman to choose to gain within the guidelines and behave accordingly. I will walk you through this beginning in the lower left with the 2009 report. This report has been used in many ways and can be used in many ways. It has informed the opinions of professional medical societies. It has been used by researchers to study women's behavior and classify their pregnancy outcome in ways that will inform future guidelines. It has also been picked up by many different kinds of media and disseminated to women, all too often incorrectly, unfortunately. In particular, it seemed that obese women had ceased to exist on many websites. Information about them has been omitted or conflated, quite incorrectly I might add, with that for overweight women. This is most disappointing and led us to develop the infographic that you will see soon. We are hoping that this is so attractive that it will be picked up by many websites with content about gestational weight gain and thus replace inaccurate information that may still be residing there. These professional society opinions that I referred to constitute a standard of care, which is both a form of dissemination as well as a requirement that physicians act in a specific way. Staff training is then needed for the whole healthcare team, and some of our products are designed to support or reinforce this process. The Dissemination Committee also identified that the electronic health record and medical payment systems, as you can see in these brown boxes here, are in places with great influence in this process, and we devoted considerable committee and staff time to determine how we could inveigle these guidelines into these systems. The answer turned out to be that the train had left the station for rulemaking related to the Affordable Care Act, which goes into effect next January. On the other hand, these guidelines were often already present for use in a number of electronic health record systems. There, the issue is whether they were active for a given hospital or physician's practice. This was not something that we could tackle from within the Institute of Medicine, given its unique mandate. However, these are quite powerful levels to pull if you can pull them, and perhaps some of you in the audience have the power to do so, and we hope you will. In the center of the diagram, we show women learning about the guidelines. They hear about them from their healthcare providers, various kinds of media, advertising, family and friends, etc. However, gaining within the guidelines is actually a personal choice, one made in the context of the opinion of family and friends, the eating and sociocultural environment in which a woman lives. And once the woman makes this choice, she still needs to behave according to this choice, which is also still subject to all of these outside influences, whether it's family and friends, the eating environment, her larger sociocultural environment, or advertising and media. As you will see, some of our materials are also designed to go to media outlets that reach important individuals in the pregnant woman's environment, and some others are to reach the woman herself. Where is the leverage here? Actually, it's everywhere in this diagram. Many parts of the healthcare system, in the information that surrounds a given woman, and within the woman herself with her own decision-making. So with that, I'd like to turn to Dr. Seeger-Rees to describe our products more fully, and we will both take questions with Dr. Catalano after her presentation.
Thank you, Kathy. So I would like to go ahead and discuss, as you heard from Michael Liu, the fact that our 2009 report had two calls to action. One was for federal, state, and local agencies, as well as healthcare providers, informing women about the importance of conceiving at a normal BMI, and to make sure that we include important information in the preconceptual time period so that women could get into a healthy state prior to becoming pregnant. And we wanted to make sure that during prenatal care, women should be offered counseling, and that counseling should include information on dietary intake and physical activity that is tailored to their lifestyle circumstances. Now, we did not go into great details into some of these dietary and physical activity counseling, and we would hope that the appropriate referrals are actually made, and we reference those in our toolkit. Now, to go over what's in our toolkit, we have developed information pamphlets for both the provider as well as the woman, and posters that are attractive that actually could be used in offices, in public health departments, in different types of healthcare wards, so that the women can very easily grasp the idea on how much weight they should gain given where they start pregnancy, whether it's underweight, normal weight, overweight, or obese. So let me begin by actually describing the provider toolkit. This is the provider toolkit. The provider toolkit is nice in the fact that it is very brief and it provides general information about why it is important to begin providing preconceptual counseling about BMI to the women. It goes into the fact that gaining weight is important for all women, but not too much weight. It actually, as you can see here, gives really concrete visual descriptions on how much weight should be gained, both by trimester as well as total weight gain. And this is important to actually prevent the confusion that has been occurring as to how much women should be advised on the amount of weight they should be gaining during pregnancy. The provider report, or portion of the toolkit, also talks about the importance of returning to a healthy weight after delivery. It is important for us to realize as healthcare providers that pregnancy offers the opportunity for us to begin the conversation and to continue it throughout the reproductive years for each individual woman. Because if we can encourage them post-pregnancy to actually not only return to their pre-pregnancy weight, but for some women to even lose more weight in that postpartum period so that the next time they become pregnant, they actually start at a healthier weight, the better we will be as a future generation for our children. And the report, this little brochure is really nice in the fact that it provides some additional resources to the provider, and it also has a little card that the provider can keep in a pocket. Now, I realize that most prenatal care providers aren't walking around with booklets anymore, and they're walking around with their iPhone. And what's very nice about our toolkit is, in fact, that if you say bookmark this URL right here, that the provider can actually have that on their fingertips at any point in time. And that's very important to have these at this particular day and age. Now let me show you the next toolkit item, which is the little booklet for the woman. And the way we actually designed this booklet was to put ourselves into the woman's perspective. And so we're asking questions and we're answering those questions for her. And you're going to see that we actually took this theme and how to get the information out to women one step further when I show you our infographic that we actually developed for the IOM. And so the booklet is very simple. It provides very clear graphics once again, because we felt it was more important to provide a simple, clear, direct message both to providers and to women at a very low level, because the report is there for anybody to go back into detail. And so this brochure actually does that. It also provides some nice additional resources to the woman, as it did to the provider, given the fact that women of higher education and who have access to the internet will want to Google some sites that can actually provide them further details about how to actually be gaining weight appropriately. This is one of the posters that can actually be used in the clinic. Once again, it's very bright, it's specific, and simple. We're trying to get the message out to as many women as we possibly can across all different educational backgrounds and cultures within the United States. Then another component of the IOM, we provided input in helping them develop the next two toolkit items that I'm going to show you. This first one is called a Healthy Pregnancy Weight Tracker. It's very nice because it is pocket-sized. This is to be given out to the woman. She can open it up, and you're actually seeing here the full version of it, where, once again, it's congratulating the woman on becoming pregnant, talking about how she needs to start at a healthy weight and to gain within the guidelines and how much weight she can gain depending on her pre-pregnancy BMI. And then it does actually provide a weight gain graph, and it shows the different lines for which she needs to stay within given her BMI. What I love about this tool is the fact that it also comes in Spanish. So we now have something readily available to give to women, and it's in English and in Spanish, so the one little item is flip-sided, so you can give this out to women. And not only can they take it home and share it with their family members, they can also, you don't have to worry about judging whether or not she can speak English or Spanish. She can actually interpret it in both ways. The next item is, once again, we're trying to answer common questions. And these are common questions that, being in prenatal care, we've heard women ask us over and over again. So the number one myth is, I have to eat for two during pregnancy. And so here we are providing a very simple message that actually tells women, no, you really shouldn't be eating for two. This tool is very nice because, once again, it comes in English and in Spanish. It's very simple. It's like a frequently asked question kind of format. And it actually helps to provide women information about things that they can ask for further explanation to the healthcare provider, thereby empowering women to gain more knowledge concerning their own condition. And that's the Spanish version right there. And last but not least, this is the first time that the IOM has actually developed an interactive infographic. We won't be able to show you it in action, but I do encourage you to go up to the website and look at this. We try to answer questions that women would want to know the answers to, sort of following the brochure that I showed you earlier. But what's also nice is that there is audio associated with it, so that women can both read as well as hear the responses to the questions. Given the fact that so many of the younger age group is actually coming through having played a lot of these different games, this is sort of one approach to sort of help women sort of keep their attention long enough so that they can get some of the answers to their questions outside of that brochure. I would think that both the brochure as well as this infographic could be bookmarks on computers kept in the waiting room, so that you could actually provide access to women while they're waiting for their prenatal care if you have a sort of computer there for women to be able to get information about diet, physical activity, and weight gain. And now let me turn this over to my colleague, Patrick Catalano.
Hi, everyone. Anne Maria, thank you for the introduction. And I think that my role in this webinar will be to see if I can help answer any questions specific as it relates to obstetrical management, and along with Kathy and Anna Maria. So I think, are we almost ready to take the questions?
We are ready for that.
Okay.
We do have one question already in the queue, so for those of you who are listening to the webinar, I hope you've solved your technical problems by now. I can see a number of you have had them. and they appear to have been resolved. If you have questions for us, we would love to hear them, so just type them into that box and send them along. Our first question is whether these resources will be made available to HRSA-funded health centers and rural health centers. I have two answers to that question. The first answer is that everything on the toolkit is available to you for your use. It's not restricted in use. We'd love you to make lots of copies of it, but of course the copies you can make are maybe not as beautiful as the originals. So therefore I need to turn to Ann Yachtine or Michelle Lawler, if either of them is available to answer this question, to be more specific. But I don't believe we have thousands of copies sitting in a warehouse somewhere that we can just send out. Is anyone able to answer this more specifically?
Yes, thank you, Kathy. This is Ann. You can obtain copies of the provider and patient booklets through the following website, www.nap.iom.edu. Actually, the patient and provider booklets, you can get hard copies from the National Academies Press, and that's www.nap.edu, and the cost is 10 for $1, so it's pretty reasonable, and then you pay shipping charges. If you just want to obtain the booklets in PDF form, or if you want any of the resources that were presented today, those can be obtained at the following website, www.iom.edu/what-to-gain-toolkit, all one word. Again, iom.edu/what-to-gain-toolkit. Kathy?
Great. Thank you very much, Ann. I'd like to move to our next question, which is how these weight gain guidelines change for adolescent pregnancies. And in 1990, the guidelines were quite specific to adolescent pregnancies, but in the research the committee reviewed and that the committee commissioned, we could no longer find justification to continue making a separate guideline for adolescents, so we did not offer one in the 2009 book. So we are asking providers to give adolescents the same weight gain advice that they give to adult women. Another question we've received is, oftentimes our pregnant women are initially seen having already gained excessively, and times half or all of what is recommended. What are suggested guidelines for women that come in their first trimester with a too high weight gain already? Anna Maria and Pat, would you like to talk about that, please?
I'm happy
Anna Maria, why don't you go first and I'll follow up.
Okay, wonderful. I remember getting this question when we first released the guidelines, and I think we need to keep in mind two things. One is the fact that we need to take women of where they are today with their measured weight. So if she's come into the clinic and based on what her pre-pregnancy weight is, which may or may not be true, has already gained too much, you need to monitor her weight from today forward and make sure that for the subsequent visits that you are encouraging her to eat healthy and be physically active, so that, in fact, she can start getting on the right trajectory from this day forward. You would not want her to start losing weight or to hold her weight constant. And I think it's really important to realize that, for the most part, we don't have a good pre-pregnancy weight to go on. And that sort of assumption that she's already gained too much weight might not be entirely correct. And it's important to move forward from where the woman is today. Dr. Cataliano, do you have any other advice?
Basically, I agree with you, Anna Maria. I think that the issue is that studies that we've done and other people have done, there tends to be an inverse relationship between a woman's pre-gravid weight and her weight gain in early pregnancy, meaning that the heavier a woman, the greater the chance that it is underreported. And at least in our particular study here in Cleveland, obese women underreported their weight by 3 kilos, a little less than the overweight, and it was a normal weight woman who basically weight that we were able to document on an electronic medical record or health record that was really pretty close on. But the principle that you mentioned is what I would agree with, is that you start with the weight that you have, particularly if it's in the first trimester, and eat healthy, exercise to the best of your ability, and then gain weight according to the guidelines. And really the key is not to lose weight based on a historical weight that you may have.
Thank you very much. Let's move on to our next question, which I've received from more than one of you, which is, what about women who are carrying multiple fetuses? This is a committee, an issue that the 2009 committee considered with some vexation, because there was relatively little additional information, and that several of the studies with the largest number of individuals were repeat publications referring to the same group of individuals. What we said in the book is that normal weight women should gain between 37 and 54 pounds. We did not have sufficient data to make any recommendation at all for underweight women carrying multiple fetuses. We further said that overweight women should be gaining between 31 and 50 pounds, and obese women should gain between 25 and 42 pounds at term if they were carrying multiple fetuses. The data did not permit us to distinguish between women carrying twins and triplets and quadruplets, or go any farther than I just did for BMI values. All right. We have a question of whether we're aware of any health plans that are helping to promote these guidelines, and if not, how can health plans support the use of these guidelines? I am not, but perhaps you are, Pat, aware of guidelines of health plans that are already promoting the guidelines?
I am not aware of any per se. I can tell you that just locally, the patients that we see, a lot of our patients are on government assistance of one type or another. And as a result of that, the local WIC programs have pretty much accepted these guidelines. But whether fee-for-service or whether other plans really endorse them to the point of supporting them, I really don't have a good answer about that. Anna Maria, do you?
No, I don't, but I don't understand why they wouldn't necessarily not be implemented in the same way I would think that you would implement sort of encouragement and maybe reinforcement for pediatric immunization. I mean, if you literally have a woman who is gaining correctly or is making progress towards those goals that are being set, it seems to me that you're actually you might be able to provide some kind of long-term benefit for her with some reinforcement. I know in North Carolina we have a sort of BMI goal that you're supposed to address for the state health care plan, and if you literally are within normal weight for BMI, then you're actually able to get at a lower rate for the state health care plan. So it seems to me that this is where we need to be creative in how we can actually provide some encouragement for women to be compliant and to create a supportive environment and an incentive for them to actually gain weight appropriately.
Okay. I want to come back to the question I just answered about multiple fetal gestation. Apparently I am confusing some of you. As you'll see on the website, the material that is provided is for women who are carrying singleton fetuses. And for such women, the recommended amount of weight for normal weight women is 28 to 40 pounds. But for women who are carrying multiple fetuses, the recommended weight gain is higher, 37 to 54 pounds. So we do have to be very careful which we're using. The major table and the materials that the major table in the 2009 book and the materials that we have just disseminated and are discussing in this webinar are for women carrying singleton fetuses. I hope
Kathy, could I just kind of add a little bit to your comment, please?
Sure.
I think, you know, as an obstetrician, I think the other issue we have with women carrying multiples, whether they be twins or greater than twins, triplets, etc., is that one of the issues not only is appropriate growth, but appropriate gestational age, because with increasing multiples, there's an increasing risk of earlier gestational age at the time of delivery. And in addition to the guidelines, as best we could formulate them, as you mentioned, is that you can also decrease that risk of prematurity by appropriate weight gain in women with multiple gestations. So not only is the growth important, but the gestational age or the avoidance of prematurity, as best we could tell, is also linked to the weight gain.
That's right. Thank you for making that point. I also want to add that the guideline that I gave you for multiple gestations is for women who get all the way to term. And of course, if the woman is delivering well before term, you would not expect her to have gained that much weight.
Correct.
Let me try another question here. We've had many women who are either vegetarian or vegan, but they still gain more than 30 pounds. What is our counseling for these groups of women? Well, for some of them, gaining more than 30 pounds is the right answer. It depends on their pre-pregnancy BMI. And it certainly is possible on using either of those dietary ways of life to gain that amount of weight. We don't make different dietary recommendations for women with these different pathways, vegetarian or vegan. Anna Maria, did you want to add to that at all?
Yeah, so I think even if you're a vegetarian or a vegan and you're assuming that she's eating healthy, we need to be conscious of the fact that calories in must equal calories out. And so then you need to take an approach to find out how much physical activity she's doing, what exercises can she do, and make sure that her physician is on board with an exercise routine. And also to pay attention to the type of beverages that she's consuming, which tends to be the easiest way of consuming a lot of calories with a short period of time and not even realizing it.
Oh, thank you, Anna Maria. We have two questions here that are related to one another that I'd like to take up simultaneously. One is whether there's an electronic prenatal grid that can be used in an electronic health record that can plot the rate of gain from entered information. And another is whether there's an app that permits us to do this. I don't have the answer to either of those questions. Do you, Anne Maria or Pat?
So it's my understanding that the weight gain grids can be easily computerized in order to go into an electrical medical record system. So Anne Yakin and I have an Excel spreadsheet that can develop the same curves that you actually see in these tools. And if you contact us, we can provide you with that. That's not a problem. In reference to the apps, I know that there's been a lot of talk about development of apps, and I would hope that someone who's very technology savvy actually goes out and creates them. There are some apps available already, but they don't seem to include the weight gain grid. And the only other thing I could say is that if you go to myplate.gov for pregnancy, that actually will provide you with an estimate of, if the woman puts in her BMI, what her gestational EDC date is and her GA is presently, as well as how much weight she's already gained. And it will give you somewhat of a dietary prescription for that particular woman. I think it also asks about physical activity. So that is, an app that you can sort of use, and I think it's the one that I actually recommend most of our nutritionists to actually implement in the clinics.
Thank you. Pat, for example, does your electronic health record permit you to plot weight gain?
Our electronic medical record that we have is called EPIC, which is one used in many places, does not have a program that you can do this centrally. What we have is that we have the ability to do it locally, meaning we can take the program that we buy and have and then adapt it at that time, but it has to only be done at the local level, and it's not going to be basically endorsed by the primary company who sells the software. So I think it tends to be something that's at the local level rather than at a national or at an industrial level. Maybe someday it can be incorporated, and a lot of times as we went through this, it gets incorporated by government mandate, but right now it almost has to be done at the local level, just pretty much like Anna Maria mentioned.
Right. So this is an unfortunate situation that we have, that when a recommendation is made, it doesn't necessarily happen instantaneously at all levels, and it's a very complicated system, as we described in the conceptual model that I presented. So if you don't see it implemented locally, please work up your chain of command and recognize it may be in the electronic health record, and that's where it needs to be changed. I'd like to turn now to a compliment we got. One of you told us that you really liked the pregnancy weight gain poster, and we're pleased to hear that, but wanted to know if it was going to be made available in Spanish. And I don't know the answer to that. Do you, Anne? Anne Yachteen, are you there?
Yes, thank you, Kathy. Thank you, Kathy. We don't have it in Spanish at the moment. We would like to do that. So in order to do that, we'll look to a future project where we can go out and get some funding and make that happen, and perhaps make the apps happen as well. So that's on our wish list. We had talked about it. We weren't able to, with the time available, get all of that done, but it's certainly on our list of things to do in the future.
Okay, thank you. We had another somewhat related question, and that is, did cultural competency, specifically racial and ethnic issues, factor at all in the development of these tools? And if it did, what were your key messages? And if not, why not? The Dissemination Committee, of which we were a part, worked with a set of really quite diverse partnership groups, and it was our fond wish to be able to do something like focus groups with our materials, but neither time nor budget permitted that. The total group of materials that you have available today, some are in Spanish and are specifically designed for our Hispanic population. Those were designed by a separate group with this as their mandate, a group with whom we cooperated. So this was definitely on our mind, but we only got partway there. Know that we were thinking this way, but it was not possible for us to do it all. Now I'd like to turn back to some questions about what about the other side of weight gain. We have this question: what about moms who lose a significant amount of weight at the beginning of their pregnancy due to nausea and vomiting? Is the weight gain goal now from the lowest weight during pregnancy or from their pre-pregnancy weight, or is the goal different? I'll take a stab at that. It's from their pre-pregnancy weight to a final weight.
I would agree with you, Kathy. That's the appropriate answer.
Right,
So
and making sure that she starts gaining weight in the right trajectory from day one, from here on out. That's very important, and it's also very important that one of the other questions that sort of tagged along with that was what happens if she's eating healthier now and being physically active, and then that's associated with the weight loss. And sometimes you actually see that, but the important ticket here is that that woman is in prenatal care and that the clinician is doing some fetal monitoring to make sure that the baby is growing correctly, and that the nutritionist is actually providing a follow-up and monitoring to make sure that she really is eating healthy and being physically active to promote fetal growth in utero.
And related, in response to another question, these guidelines are designed to be relative to a woman's pre-pregnancy weight, regardless of how much weight she has gained or lost at the time she shows up at her first appointment. So on the other side of that, losing weight early in the pregnancy, we have a listener who would like us to discuss what health risks there are to the fetus when this occurs. What about when the weight loss is due to changing to healthier behaviors? I think Anna Maria was just trying to answer that. Pat, do you want to take a whack at health risks for the fetus when women lose weight in the first trimester of pregnancy?
I think the most common situation is when women have hyperemesis or nausea and vomiting in early pregnancy. And, one of the keys in reproductive biology is that in the first half of pregnancy, the weight gain is primarily maternal weight gain, and it's growth of the placenta per se. And it's only in the last two-thirds of pregnancy or the last trimester do you actually get two-thirds of fetal growth. So the key is that early pregnancy weight gain is important in order to establish the basic nutrient stores and resources for the mother for late pregnancy and also for placental development. So basically, women who lose a lot of weight in early pregnancy, there's an increased risk of having babies who are smaller, and primarily because of poor placental development. And you can have poor placental development not only because of nutritional issues, but you could have them because of mechanical issues. For the sake of discussion, someone who has lots of bleeding or partial abruption early in pregnancy, they may not have a fully functional placenta, and that could also lead to problems with decreased growth that don't become apparent till the end of pregnancy or the third trimester.
Okay, thanks a lot. We have a comment from a listener asking us why we decided to use the terms overweight, underweight, etc., instead of the BMI ranges for those terms. And by that I assume the listener means women with BMIs of X to X or Y to Y, Y to Z, etc. Is the assumption that they will always refer to a BMI chart so the patient knows what category she falls in? Well, yes, we did make that assumption. And the questioner goes on to ask or comment that we find the term obese can be highly emotional and can disengage a client, whereas the term BMI term might not be as emotionally charged. I expect that many of you have this emotionally charged reaction. The committee was using these terms from a scientific perspective when we wrote the 2009 report, and we continue to use them that way. We do consider them to be objective terms that describe the BMI ranges. It didn't occur to us to use numbers to describe the BMI ranges in shorthand. Would either Pat or Anna Marie like to add anything to my answer?
No, I mean, the numbers are actually there in the healthcare provider. I think we actually felt that using those terms might be more intuitive to the woman as opposed to her remembering the cut points for the different BMI categories. But I also think that, like anything, it's all a matter of sensitivity and developing a rapport with a patient when you're actually talking to them about their weight status. And so an individual who's actually good at this would find it easy to be able to help that individual woman understand that, this is the best amount of weight gain given where she's at in her weight classification. And we're not necessarily making any judgment calls on her.
I think that's true. I think that when you, especially if you have a relationship with the patient, and I think a lot of healthcare providers do, you see them on a regular basis, that one can address these issues on a little bit more personal level, and I think that it's not as much of a problem as one would think. But again, it really depends on your relationship. I think seeing a patient for one visit may be a bit offsetting, but again, if you're seeing a woman over time, and this is one of the issues that you're addressing, I think that, to be honest and sensitive to the issue is important, but also being truthful.
Right, right. You can't get a change in behavior if you're not really talking about the same thing. Okay, I'd like to move to a question in which we're asked how we suggest that our listeners work with these guidelines with their local clinics, and especially when local physicians may wish minimal gains for overweight or obese clients. And by minimal gains, the questioner means less than 10 pounds. That's a real challenge because we aren't suggesting less than 10 pounds for much of anyone. Pat, do you have anything to help us with that?
I wish I did, but I don't. And the reason is that it's very interesting. If you look at the latest guidelines from the American College of OBGYN, they basically endorse the guidelines that were put out by the IOM committee. However, they have a caveat stating that if a woman wishes, and again, really referring to obese women primarily, who wishes to gain less weight than the guidelines, they need to do this in conjunction with the healthcare provider in assuming adequate growth of the baby. So they kind of leave it a little bit loose in that regard, and I think that, in my mind, what we do is just say these are the best guidelines we have. It may be best in some situations to gain less than the guidelines, but on the other hand, we don't really have the information or the evidence to say it absolutely is. Now, on the other hand, you do have women who, despite is an apparent healthy diet, don't gain a lot of weight, and the babies appear to grow, so that I think in one sense, as long as someone is eating healthy to the best of your ability, active, and there's good growth, I think that while we like to aim for that minimal of 10 pounds, I certainly wouldn't, at least clinically, put someone on a supplement just to reach an arbitrary weight gain. But on the other hand, I wouldn't go to the other direction and recommend that someone actively try not to gain the minimal amount of weight, if that makes any sense.
Mm-hmm. Thank you very much. Let's move to another question. This listener wants to know how complications of pregnancy, such as preeclampsia, gestational diabetes, and premature rupture of the membranes, affect patients' abilities to abide by these goals, especially with a lengthy hospital stay. That certainly makes it more difficult. And I think our primary response would be to try and treat these medical conditions, which are indeed quite serious. Pat, would you like to add to that?
Yeah, I think that there are some of these conditions. Let me take the first one, preeclampsia. One of the hallmarks of preeclampsia is increased weight gain, primarily because of increased edema, third spacing of fluid. And so if a woman has preeclampsia, it's not uncommon that she's gaining excessive weight, but that weight gain is a fluid weight gain that is not related to nutritional issues, meaning a poor diet, poor protein, and so forth. It's related to the underlying disorder. So I think in that particular case, you wouldn't want to put a woman to start restricting her diet because she's gaining excessive weight with a diagnosis of preeclampsia. You have to keep the diagnosis in mind relative to what's going on and adjust appropriately. So again, this is where I think you really need the healthcare provider to have some input in recognizing that, quote, excessive gestational weight gain may be a complication of the disorder rather than a primary issue of nutrition. Go ahead.
No, I'm just
Let me just address the gestational diabetes issue. Relative to the gestational diabetes, what we and others have found is that when you start treating women with gestational diabetes, particularly if their diet hasn't been ideal, that there will be initially a small loss of weight. And what we see clinically is over a period of maybe 1 or 2 weeks, there's a loss of a couple of pounds to 3 to 4 pounds. And part of that is trying to get the woman to realize that the treatment of a diet in women with diabetes is not weight loss. The treatment of the diet in people with glucose intolerance is achievement of normal glycemia. So while you may restrict certain types of carbohydrates, the simple sugars per se, etc., the point is that adequate gestational weight gain is important in these women. But obviously, because of their underlying disorder of glucose metabolism, there is, at least clinically, I see a lot more women pay stricter attention to this issue. And you have another guideline beside weight gain, which is home glucose monitoring, which can help with this issue as well. And finally, the last example was given was premature rupture of membranes. Keep in mind that at the end of pregnancy, the amniotic fluid accounts for about a liter or 1 kilogram or 2.2 pounds in weight, and so that with rupture of membranes, unless it's reaccumulating, you need to really keep in mind that there's a 2.2 kilo normal amount of weight gain which is lost, and just to factor that into your assessment of her weight gain. But most of these women are in hospital and under really close supervision, so it's really not an outpatient issue but an inpatient issue.
Great. Thanks a lot, Pat. We have another question about weight. This one relates to whether there are established weight loss guidelines for the immediate postpartum period, and is there a developed tracker or plans to develop one to pair with your pregnancy weight tracker? Well, I have to say to this listener, we would love to be able to do that, but we have not had that as a goal, and we were not funded to do that. I think it would be enormously helpful to women to know what reasonable weight loss guidelines there were. There are some for lactation in terms of rate of weight loss, but not every woman is breastfeeding. There also are some guidelines for weight loss in the most immediate postpartum period when we expect women to lose a lot of fluid. But I don't have those numbers at the top of my head. Did Pat or Anna Maria, do you wish to comment?
I don't have that number on the top of my head either, but I think what we find is that interventions during the postpartum period need to be taken into consideration that the woman now has another family member to take care of. And so time is of the essence. And it's something that needs to be done cautiously, in the sense that you don't want her to all of a sudden don't expect them to participate in a heavy dose of classes, because it's really hard for them to accommodate those kinds of schedules. But individual tailorized messaging, there's a lot of programs right now using text messaging that seems to be a successful tool in helping women lose weight during the postpartum period, as well as in doing a mix between physical activity and diet support groups for women, and using the Weight Watchers program actually to accomplish that. The one thing we do realize is that some women during the postpartum period start gaining weight. Well, that should be an automatic alarm to say, uh-oh, something's wrong here, that should not be happening. And those women should really be targeted to get some help in not having them start going back up on their weight, but rather continue with their weight loss, either, like I said before, into they're entering their pre-pregnancy weight or actually coming to a much healthier weight, so that they're ready for the next pregnancy when it actually occurs.
I think that's a really good reminder for women that they should not be gaining in the postpartum period. We also need to remember it's very challenging because the woman's whole life organization has likely changed with the birth of this individual child, but that is something she can use as a marker. And if you are the person caring for her, this is something you could ask. And if she's begun to gain weight again, now would be the time to do something about it. I want to speak to our listeners directly. We've had lots of questions. We've got time for lots more. Now would be the time to enter your question in the question box so that we can get to yours. I have another question here from a listener who sometimes worries that women on special diets do not get enough protein, even though they gain adequate or excessive weight throughout pregnancy. You know, we have a long history in this country of worrying about protein intake, and it's probably the macronutrient we need to worry least about because our diets really have a lot of protein in them unless the woman is following some very different dietary pattern. So I don't think it's something we see very often, but Anna Maria, you're better at this than I am.
No, I agree with that statement. That's absolutely true. The protein requirements for pregnancy are not very large, and most women, even outside of the pregnancy state, consume in excess of 60% of their protein intake, if I remember correctly, based on the latest NHANES data.
Yeah, it's really quite high. So that in general, we would say that's not likely to be a problem. If you have a particular patient with that issue, you can of course discuss it with them, but protein is not usually a limiting nutrient. So another question we have here is, if the outcome of pregnancy is determined in that first 3-month period, and of course there are some outcomes of pregnancy determined early on, would it be possible to change the paradigm of prenatal care so that women are seen more often in the first trimester? And if so, how could that be accomplished? I think that's a tremendous challenge because we're having a hard enough time getting women into care in the first trimester as it is. And we may be doing very little in that first trimester besides ascertaining that they are pregnant and making sure that they have a fetal heartbeat, unless the woman has pre-existing medical conditions that cause us to be concerned.
Kathy, I would like to add, though, that I think instead of saying that they should be seen more frequently in the first trimester, I think we need to figure out how we can have women come into pregnancy at a healthy state to begin with. Preconceptional care is the most important. And so if a woman comes in both in a physically, emotionally, and nutritionally optimal state, she is more likely to have better birth outcomes as well as less pregnancy complications.
Anna Maria, I couldn't agree with you more. I think that's really the key, that if you can set that bar, the earlier you can set that bar, and ideally prior to a woman's conceiving, which includes things like planning a pregnancy, which 2/3 of women in this country don't do statistically, and ideally getting into that kind of mindset, just like we often talk about a woman who has a medical condition. You're much better off getting your blood pressure under control before you get pregnant rather than when you're pregnant. And certainly the diabetes issue, there's no question that good glucose control prior to conception is what you need to decrease the risk of not only early spontaneous pregnancy loss or miscarriage, but the high risk of birth defects or congenital anomalies. So, I mean, those are the obvious ones. The issue is that being overweight or obese isn't considered to be in the nature of those problems, but it's true because overweight and obese women do have an increased risk of increasing spontaneous miscarriage and an increased risk of congenital anomalies. So we just kind of assume it's not as big of an issue, but in point of fact it really is as much of a serious issue for those very real complications of pregnancy.
I mean, this discussion brings us back to what Dr. Liu said at the beginning, that our challenge is to help women before reproduction, during and between reproductive events, and of course after they're done reproducing. We have to be thinking from a lifelong perspective and not miss any of these opportunities to work with women to help stay healthy. So question from a listener about how to address the problem of a woman not gaining any weight but her physician states the baby is growing fine. What do we do for that woman to help her to gain some reasonable amount of weight and not conflict with her physician? So for that, I will turn to our physician.
I think
what would you like another healthcare provider to do when the woman isn't gaining any weight?
I think that it would be important that, one, we document exactly what the weight gain has been or not been. Two, keep in mind that there's no way to assess fetal growth relative to the risk of a large or small baby in most cases. I mean, I'm excluding congenital infections or congenital anomalies until the 3rd trimester. So that in many ways you really don't see the differential in growth until you're past 28 or 30 weeks. So that anything before that is really not that helpful. So I think that one basic thing to do is to have a woman see a nutritionist to make sure, in addition to what the physician has to say, that someone who really works in this area can take a nutrition history and really determine, is the woman eating the appropriate and the right amounts of food and the types of food. The other thing that we've kind of don't spend as much time on, because we talk about weight gain guidelines and intake, and Anna Maria, I think, alluded to this, is the issue of energy expenditure. And keeping in mind that the energy expenditure in a normal pregnancy varies tremendously. And again, I'm speaking more as a researcher here than a clinical obstetrician, is that most of the guidelines looking at 300 calories a day as a ballpark number, and that's still in a lot of the OB textbooks. But in point of fact is, when you look at some of the research that's been done, energy expenditure in pregnancy can vary to a fraction of that amount for someone, say, who's insulin resistant, for example, obese women, to a much higher energy intake than 300 calories a day for someone who is involved in competitive athletics or does a manual labor type job, which isn't unheard of today. So you really need to look at all of these issues very carefully, and like anything else, if a woman is concerned about this, there's nothing wrong with asking a provider for a second opinion, whether that be with another obstetrician or maternal fetal medicine person, or at the minimal a registered nutritionist to address some of these problems, or questions, I should say.
We're being asked that in addition to this broadcast, what else is being done to increase the number of physicians actually talking about proper weight. The participant says, I'm a health educator who could not get my physicians in 2 different states to tell me what a proper weight gain would be. Well, we regret to say that research is very clear that our physician workforce who care for pregnant women are not equally well informed about weight gain, and moreover they have some difficulty knowing how to help women gain within the guidelines. It would be wonderful if we had the ability for physicians to refer to registered dietitians for help with weight management whenever that problem manifests itself, but we are not there yet in terms of our reimbursement policies. As part of the totality of the weight gain report, we have done some other things. At the time the report was published, we published a commentary in one of the most frequently read obstetric journals to help individual physicians know about the guidelines and how they should be used. That paper was actually required reading for relicensing for obstetricians around the country. So we've certainly made an effort in that regard. And we need to keep the pressure on. And we're hoping that these new tools, as you use them, if you have questions and want to collaborate with the local physicians, now you have some things to work with. So we hope that will be helpful. Pat, did you want to add anything else about how we can get physicians to pay more attention to this?
I think I agree exactly with what you said, Kathy. The only thing I would add is that if the physicians are obstetricians, there is the recent report by the American College of OBGYN and the practice guidelines, which do basically endorse the IOM guidelines for weight gain with the one caveat I mentioned earlier. So I think that if someone is dealing with a physician who isn't aware of these, then those guidelines can be found in the American College of OBGYN, and they're free to download.
Thank you very much.
So I think that they are there, and they are the guidelines that people use or should be using.
Or should be using, right.
I think they should
be.
Mm-hmm.
This same individual asked us, do waist circumference measurements during pregnancy correspond with weight gain recommendations? For example, if first trimester, so many pounds should be gained in the first trimester, how does that correspond with the expected waist circumference? We are unable to answer that question. That's not something anyone has studied that I know about. Would either of our other panelists like to correct me on that?
No, you're right.
The only thing I can add is that one of our fellows did a research study looking at changes in weight gain with distribution of subcutaneous fat in early pregnancy. And, well, biology takes over, and just like when females gain weight, they tend to gain it in the pair distribution. Early weight gain in pregnancy, at least for subcutaneous fat, appears to be anywhere between the lower rib cage and the middle of the thigh. So I don't think abdominal circumference would be helpful, but that's based on a small number of patients in a research publication.
Right.
And obviously after the first trimester, it's very difficult to make any sense out of a waist circumference.
Right, right, because of where the uterus is. So while we are using waist circumference to help us understand cardiovascular risk of cardiovascular disease in non-pregnant individuals, it's really not helpful in pregnant individuals. We are using, in some parts of the world, although generally not here, you can measure the woman from the symphysis pubis to the top of the uterus to determine the duration of pregnancy. And of course, if you were to wrap the tape measure in the other direction, you don't get quite exactly the same information. Turning back to the postpartum period, we were previously asked about recommendations for postpartum weight loss. And this is a question, how long postpartum should the pregnancy weight be lost? Well, I think that answer to that depends a bit on the woman's behavior. If she is breastfeeding, and she gained a reasonable amount of weight, and she, let's say, exclusively breastfeeds as suggested, she will probably lose her pregnancy weight within 6 months. But if she's not exclusively breastfeeding or she gained excessively, it will take her longer, unless she does something in addition, changes her food intake, reduces her food intake, or exercises more to meet that. And of course, most women in the U.S. are actually not meeting our breastfeeding recommendations, so it's likely to take longer. Do Pat and Anna Maria, do you have a sense of how long it's taking the individuals that you work with?
No, I think it is highly dependent. And even for women who are breastfeeding, if they are actually consuming more calories than what they did during pregnancy, because they think they're supposed to be consuming more during the lactation period, it's going to be harder for them to lose the weight. So one of the things that we have to remember is the fact that maternal fat stores are laid down during pregnancy, and those fat stores not only come into play in the third trimester in case you need them there in order to provide nutrients for the fetus, but they're also there during the lactation period to help you mobilize those fat stores to produce milk. But if you're consuming calories on top of, you know, what your energy expenditure is, it's just going to take longer. So it's highly dependent on women and their behaviors, their sleeping patterns, their whether or not they're breastfeeding, their exercise routine. And the one thing we do notice is that if you haven't really lost it by 12 months, it's going to take you a long time to lose that weight. because it should be lost within the first year.
Right, right. And most of it will come off in those first 6 months, partly because of the water loss and secondly because of the effects of breastfeeding. So again, if women are not losing weight or they get part way to their pre-pregnancy weight and don't continue to lose weight, that's a cue to them that it is time to make more of an effort to get back to their pre-pregnancy weight. It will be better for them and for any subsequent children they have. Again, I'd like to invite our participants to send us their questions. We do have some additional time still and an opportunity to answer more questions. Another issue that relates to the postpartum period is that the medical model for the postpartum period, of course, does not include any visits except the one at 6 weeks, which is mostly for contraception. We don't have a model for post-conception care or for weight management. It, of course, would be ideal to see women multiple times during that period. But the committee, the original weight gain committee recommended that women should be seen this way, but it has not entered into the into the implementation of the Affordable Care Act, to my knowledge. But it certainly would be appropriate for us to be spending more effort to do that. Some of the research that's been done in my group indicates that really nobody's looking after the woman in the postpartum period. It's not something that's the obstetrician's job. It's not the pediatrician's job. She's not being seen by the midwife anymore. She just sort of drops off the face of medical earth. So that is a real challenge for us to provide women with care at that time. Pat or Anna Maria, did you want to comment on that?
Well, I agree with you.
My only sort of comment would be that this is where we kind of believe that there needs to be a radical change in healthcare. And the mother, from the beginning of pregnancy, it would be very helpful if we start guiding what her choices are and what her behaviors are so that then she can apply them to the infant in trying to establish good eating habits and physical activity habits in that child as he or she grows older. And so I think that family approach and teaching even the cues of when a baby is hungry and filled, tummy is full, are the same kind of things that women actually need to be able to understand within their own bodies so that they can then actually be a better parent to the child. And there are some intervention studies right now going on that start early on in pregnancy and teaching moms about this, and hopefully they'll prove to be helpful for both the mother, the child, and other family members.
Mm-hmm.
I think the only point I would add to this is that theoretically, you know, most healthy women, even if you're overweight, unless you have, or obese, and you have a comorbid medical condition, whether it be diabetes or hypertension, are usually not followed because they're not considered, that in and of itself isn't considered a medical problem. And as a result of that, I agree that a lot of these women do fall off the medical playing field. And, you know, the goal would be either whoever's going to be the healthcare provider for this woman when she's pregnant, you know, theoretically could be the healthcare provider for this woman when she's not pregnant and really have a context of continual care. The other way of approaching it, of course, is if you have a multidisciplinary approach, and this would be the obstetrician or the obstetrical healthcare provider not only working with the pediatrician relative to the baby, as Anna Maria suggested, and I agree with, but also to the who's going to be following this woman with her general medical care, her preventive health care, whether it be for her weight, which we're addressing today, but whether it be for other factors such as her contraception, her history of, you know, psychiatric issues or stress issues. And there's a whole host of things that really need to be addressed, and either there's going to be some continuity of care either from pregnancy, where at least people get into the medical system, but also the preventive health care after they've been seen. And I think this is a problem that a lot of people are wrestling with, how best to do it, and whether it's going to be a research approach or whether it be a public health approach is yet to be seen.
Well, this is a case where using a family medicine practitioner, no offense to my obstetrician colleague here, can be very, very useful, because then you can think about family-centered care. Another group that can be of great assistance here is the WIC program, which sees more than half the infants in this country. They are seeing the mother at the same time. Their job is not just to deal with the baby but the mother. They're one of the few groups that have that issue. We probably do still have some places in the country, although certainly not the county I live in, where public health nurses are seeing new mothers. That's another opportunity. And of course, it's a marketing opportunity for the obstetricians to find a way to keep women in their practice even if they're not pregnant. These are all ways in which women at the moment are not as served as they could be, but they are opportunities. Another question we have is that in most of the programs that I've just been talking about, and we've just been talking about, the clinician is focused on the purpose of the visit. And an issue for us to discuss is whether clinicians can seize opportunities in other visits, such as well-child visits or family planning, to talk about healthy weight before, during, and after pregnancy. This is a real challenge because many of our clinical practices are very constrained in time, and they are specific for a given individual. Our pediatricians don't treat the child's mother. They can refer, but they don't treat, and that's a real challenge. Pat, do you want to speak to that at all?
No, I mean, I wish I could speak to that. I'll put it that way. I think that we are constrained with time with seeing patients, and you can just about get through what you need to get through with. And again, when you're talking to someone like me, I'm such a specialized person, seeing primarily women who have diabetes or who've had bariatric surgery. It really needs to be, as you alluded to actually earlier, at the level where someone is dealing with primary care, the family physician, the general OB/GYN. I think this is really where it needs to be done in a centering way to make it cost efficient. I think people are starting to look at these issues, and maybe Anna Maria may have some comments on it, that when you get groups of people together and try to do it from a centering perspective, you may get better results than trying to do it one-on-one when you have such a limited amount of time.
Can you explain for our participants, our listeners, Pat, what you mean by centering, please?
At least what I mean by centering is that when you have a group of people where they're taught about whether it's nutrition, what I do relative to glucose control, what's the implications, and instead of it always being one-on-one in a short visit, that this would be something that would be done, say, in our clinics, at the beginning of the clinic, at the end of the clinic, while people are in the waiting room, so that they can get a detailed approach to it. Now, whether you do it from a person doing it, or whether you have a video, or whether there's a question and answer session. The other part of it is that it's not always provided by the healthcare professional. It doesn't have to be a physician. It doesn't even have to be a nutritionist. Sometimes, depending on the population you're dealing with, someone who is knowledgeable but can know the issues that exist. So, for example, in inner city Cleveland, we have people who have a better handle on what's available and how do you get to a good supermarket to find the right kind of food that won't cost you an arm and a leg, and how do you approach that? So I think the centering brings it right down to the level of the patient you're dealing with, and it varies on the population.
Okay. So we have another question here of what is the in utero risk to consuming a high-fat or high-sugar diet for fetal development? And do we know the future risk for obesity in the offspring? That sounds like one that's right up your alley, Pat.
Yeah, well, we certainly know that women who have hyperglycemia, in the example is gestational diabetes, that their babies are bigger because they're fatter. We also know through 2 randomized controlled trials, one here in the U.S., which we participated in, and one in Australia, primarily Australia, New Zealand, that treatment of women with gestational diabetes by maintaining glucose levels in what we consider a normal range, their babies are at a healthy weight, and primarily because they're less obese. The issue about obesity is a little bit tougher because there are lifestyle intervention trials during pregnancy for women who are overweight or obese have not been as successful relative to the issue of fetal growth. They've been more successful in avoidance of excessive gestational weight gain, but have not been so successful relative to the issue of large babies. And we don't know exactly the reason why. Is it because it started too late? Many of these studies are starting in the mid-second trimester, 15 to 18 weeks, when almost a half of the pregnancy has been completed and you're getting to the placental issues I mentioned before. But there are studies that are ongoing, one I know of which at the University of Colorado, where looking at obese women and trying to alter the nutrient intake as it relates to things such as saturated fats and so forth, which may have effects not only on the caloric intake, but their ability to affect inflammatory responses, the issue of probiotics, the microbiome. I think that there's getting a lot more interest in research into not just the simple nutrient components per se, but what is their effect in their ability to have specific effects on outcomes. Hopefully that's not too confusing.
Thanks a lot, Pat. So I think we're going to bring the webinar to a close at this point. We really appreciate all your fine questions, and I, as somebody who's generally not in the classroom and instead of a who is in the classroom instead of a webinar, it's really much easier to do in person, but we appreciate your cooperation. So what we wanted you to know in this webinar is that with the sponsorship of HRSA and other sponsors, and particularly for the Weight Gain Report, 7 different sponsors, we have really given attention recently to weight gain during pregnancy and helping women, developing new guidelines and helping the women to gain within them. In this webinar, we've wanted you to know what tools are available. We've given you access to them. You can see the websites there, and you'll hear more about that in just a minute. We'd like to see you put these to use. We'd like to see you think big, ask where your personal leverage is in terms of weight gain, and as well as helping women to be at a healthy weight when they conceive and return to a healthy weight postpartum. It really is time for a radical change in the health care of women if we want them and their young children to be as healthy as possible. So we thank you again for your participation, and I'd like to turn this back to Anyak team.
Mm-hmm. Thank you, Kathy. And I, too, would like to thank everyone who participated today. Don't forget, you can download a free copy of our report in the PDF form from National Academies Press, and that URL is www.nap.edu. The summary report for the workshop that Kathy was talking about will be coming out shortly. We're going to release that on September the 16th, so look for that. When you exit this webinar, you'll be redirected to our report page for that information. Again, this webinar has been recorded and will be posted along with the PowerPoint presentations on our website, www.iom.edu. And with that, I would like to thank our speakers, Dr. Michael Liu, Dr. Kathy Rasmussen, Dr. Anna Maria Segeriz, and Dr. Patrick Catalano. And thank you all again for participating. Have a great day.